thanks to the organizers for inviting me. I haven't been back to Botswana in a while, so it's always a treat to be back and to see everyone. I'm not a very good student, and I'm not following the directions very well, so I will not give an overview of West Africa as Saidi maybe thought I would. But what I will do is talk to you about where I think we're at with Nigeria, which obviously is a big country in West Africa, and then focus in on a topic that we've been dealing with in Nigeria, which is drug resistance, which I think has implications for treatment as prevention. So I hope that that will be useful for the discussions and topic of this meeting. So this is just the experience that we had through the Harvard PEPFAR program. Nigeria was one of the 3 countries we were involved with. Tanzania and Botswana were the other 2. And over the period from 2004 to 2012, we were able to provide treatment to about 100,000 patients who were in need. And I would say that that is about 20% of what the country was able to accomplish by 2012. Recognize this is a country with a population of about 168 million, and so their burden is thought to be about 3.5 million people living with HIV. So despite all of the enthusiasm for treatment as prevention and the success potential for PMT-CT and an AIDS-free generation, one of the real problems that I think Nigeria exemplifies is that they're very far behind in their coverage, 30% for ART, maybe 25% for access to antenatal care services. And sadly, no matter how else you looked at the numbers, Nigeria, just because of its sheer size, would bring down all of the statistics for the region. So I think it's something that we need to think and have some perspective of when we recognize it's one of the largest countries in the sub-Saharan Africa. So our program had a head start by having funding from the Gates Foundation, and we were able to partner with university teaching hospitals there in 6 different states, and those became the foundation of our program that scaled up over the years. And that program has now transitioned over to a local NGO that we helped form called APIN, AIDS Prevention Initiative in Nigeria. And this is the location of the sites, at least until about last year, and they've moved some of them around in terms of PEPFAR funding recently. But we had a very nice network of big tertiary teaching hospitals with secondary and primary sites. Now, one of the things that I think is useful to think about in terms of treatment as prevention, and this was sort of raised a little bit in the discussion, is that Nigeria is a country where the prevalence, nationwide prevalence, which has been tested pretty regularly and it looks to be pretty accurate, has never gone above 5%. So they have a huge burden, but the prevalence was never high. And that means that the requirement for significant counseling and testing is really there if you want to reach the kinds of numbers that we're talking about. So I give you all of the different activities that are covered through PEPFAR or any of these other programs that support treatment and care. But importantly, if you want to treat 100,000 patients, you had to screen over 1 million. And that number is actually going up. As probably the treatment programs are having an impact in the country, the nationwide prevalence looks like it's stabilizing or going down. It's now below 4%. And that just means that you will have to do much more testing here in order to identify the people that you want to put on treatment, or to identify your discordant couples, your pediatric cases, et cetera. So it's really a challenge, particularly when we think about we're only halfway or a third of the way where we need to be in a place like Nigeria. And obviously, lab and infrastructure are important, and they're very important for the next topic that I'm going to try to raise. This is just something that we used, and it lets me just tell you that in these big university teaching hospitals where we had been able to provide a lot of support for monitoring and evaluation and also laboratory, we were able to have electronic records, and still do for all of our patients, and have viral load, DNA PCR, laser-based CD4s, and regular monthly pickups being recorded in this manner, so that you'd had lab values that would alert clinic coordinators when there was a panic hematology or chemistry, pharmacy pickups, and then this graphic representation which allowed both the physicians but also even the patients to be able to better understand what the monitoring parameters meant with respect to their treatment course. And we found this to be a very useful tool that we continue to use in the program. So along with the laboratory work that we put in for regular monitoring, we felt it was important that we begin to look at surveillance for drug resistance. And we've put in sequencers at 3 laboratories at university teaching hospitals, at Ibadan, Jos, and also the National Institute of Medical Research in Lagos. And this is the data off the first 400 patients failing first-line treatment. And what it's showing you is the subtype that was derived based on just looking at sequence from RT and protease. And I raise it because I think West Africa is a little bit unique in parts of the continent because of the diversity of subtypes. Not only are there a diversity of HIV-1 subtypes, but there is also HIV-2, although quite a lower prevalence, but also not well diagnosed because we don't do that anymore. And rapid tests don't discriminate, and most of the funders don't want to even look at it. So we have almost no idea of what the status is for HIV-2. And the only way we're able to look at HIV-1 is if we're able to look at these subgenomics that were done for another reason, which was to look at drug resistance. We're able to look at subtype. And you can see that there's a difference in subtypes, and recognize that West Africa is unique. Not only do they have evolving subtypes like this G prime, there's also a subtype A3, which is rapidly increasing, and then 2 stable circulating recombinant forms, and a number of others. But I think West Africa is sort of unique in the molecular epidemiologic perspective because of the subtype situation. And we wanted to ask the question, and many of you have seen this before, are the drug resistance mutations the same or different than subtype B? And for the NNRTIs, the main ones are exactly the same as what we would have predicted from subtype B studies, but there are a few differences that are seen with CRFO2, more commonly the V90, or subtype G, more commonly CRFO2 and the AO98, and in the NRTIs it was similar. It was very reassuring that the main mutations that we're looking at and that we've studied before, the M184V and the T215 are the same, and then again 2 TAMs that are a little bit different with the different subtypes. So if you do the analyses, you can see that there are some subtype differences, that you either have a higher risk of getting the mutation or a lower risk. And I think that's something that we want to continue to look at to the extent that we're able to follow these different subtype infections. But I think one of the reasons why we were so interested in the issue of subtype to begin with was not because of RT, but because of protease. Because we know that in the HIV-1 subtypes that we're looking at in West Africa, many of them have these protease polymorphisms that are seen in virtually all of the subtypes of the region. And so these M36I, I13V, and H69K are very, very prevalent. And of course, the question was, does that mean they'll develop protease inhibitor resistance more rapidly? This is a study that Holly Ruiza just did, and this is patients now who were on second-line PI-based therapy. 670, 10% of them failed, and this is what's going to happen as these programs mature. You will have second-line failures, and we will have to start to look at it. And I guess we do see these polymorphisms. They're just polymorphisms. They're not classified as major PR mutations. They're not. We do see some of these major PR protease mutations, and they are subtype related. And we do see differences by time on therapy. So once you're out at 2 years on a second-line therapy and you've failed, you have an average of 5 mutations, which means that you are required to go to third line. That is, of course, an issue that international donors and the countries don't even want to face at this point, and it's something that we still feel is important to have this capability in our programs so that we'll be able to guide the treatment programs to the extent that we can. And just to end up quickly, I think another thing that we're trying to do is to develop some cost-effective methods to do some of these analyses, both for surveillance and also for patient care. This was developed by a postdoc in my lab from Tanzania. It's a ligand assay, and it's targeted specifically to the drug resistance mutation and to the subtype. So for every subtype, we've done 4 mutations: M184V, K103N. I won't name them all, but he ended up having to do about 16 different combinations to be able to get the most prevalent drug resistance mutations that we would have expected in West Africa, and he's now doing that for Tanzania. This is a picture of him when he graduated, and he's now at the Muhimbili lab. He's designing more primers and is supported to do this for the Tanzanian mutations, and we're hoping to develop this into an ELISA format so that drug resistance can go down to a reasonable price on an ELISA format that will be useful both for ART but also for overall surveillance. So thank you very much.